Okay, here's my lecture for the introduction of Research 1. The chapter is actually called Integrating Evaluation and Practice, but it's an introduction to the entire book. So I hope that this lecture goes okay. I've practiced and practiced, so I'm ready for real time right now. In terms of an audience, I do have one of my cats here who has his back to me and is half asleep. So that's pretty much all I have. So hopefully this will go okay. I'll try to keep my voice up, but if you have any problems hearing this, for goodness sake, let me know instead of suffering through the entire semester not being able to change sorry, something popped up on my screen I wasn't expecting. So let me know if you can't hear or if you have problems with these online lectures. Like I said, this is a first time I've done this. So the first question you might be asking you is, why are you here? The obvious question is it's a required class for getting your MSW. But in terms of my hope and what you'll be able to do at the end of the class is to improve your practice by evaluating it using single system design, and that's what the course is going to focus around, teaching you how to use single system design. What is single system design? Single system design is very different than a classic research design where you might have a you might measure things before the intervention and then after the intervention. It's a plan to identify and measure something the client wants or needs to change, measure it repeatedly over time, usually before, during, and sometimes after an intervention, looking at a follow-up data, and using this information to help your clients in making humane and effective practice decisions in a timely fashion. Here's a example of a very simplistic single system design. Let me just orientate you to the graph. Along the the vertical axis is the dependent variable, is the number of meals eaten in the dining room, let's say, and then always in the single system design, along the horizontal axis is time. And in this example, it's day. It could be weeks, it could be months. But the situation in this example is that previously the dining room had been used by elderly residents in a nursing home, and then they noticed that fewer and fewer meals were being eaten in the dining room. So what they decided to do, they decided to put into place a new intervention, a new plan. Their intervention was to bring in a designer, decorate the dining room, make it more cheerful, put up useful information about recreational events, and then also to go by each of the residents' rooms and personally invite them, give them a copy of the menu, and provide them transportation if they wanted it to the dining room. So what you see here is data before the intervention in the baseline. The vertical line on the graph represents the division of baseline and intervention data, and you'll see at the beginning days there might have been, for the first 4 days, there might have been some, old habits, but then you'll see that eventually that there were more and more meals eaten in the dining room. So that's just a simple single system design. Here's a slightly more complex single system design. You have a client who has depression problems. Again, you see depression represented on the vertical axis as a dependent variable. Here we're using a Beck depression inventory, which I believe ranges from 0 to 16, and we utilize this inventory every week, so we're collecting data every week. The letters, A stands for baseline, and the letter B stands, A stands for baseline, that's right, and any letters B through Z stand for intervention. And you might find in the early days of single system design, the letter C was used as a follow-up phase. However, I will not be using that convention. You might see that in some examples in your textbook. You certainly may see that in the article critiques you have, but in all the examples that I will use, whenever there is a follow-up phase, I will write out the words follow-up. So in this example, A, baseline, means no intervention. B, in this case, stands for cognitive behavioral intervention. And you can see that after 5 weeks of cognitive behavioral therapy, the client had not progressed very much. So what they decided to do is combine cognitive behavioral therapy with psychotropic medicine, Paxil, and that's what you see. When you see 2 letters combined, BC, that means those interventions are combined and they're taking place simultaneously. So you can see, and this is I think well known, that the best practice for depression is some type of psychotherapy combined with some drug therapy. So that's another example of a single system design. In terms of what is practice evaluation, and similar to single system design, the strength of single system design is that it's systematic, ongoing, and more or less objective. And I say more or less objective in that from research 1 and prior research that nothing that we measure can be totally objective. It's fraught with error and human biases, and but we do our best to give an objective determination of whether or not, at least in practice evaluation, the determination of whether or not we are achieving the objectives and goals that we set with our client. In terms of why would you want to evaluate your practice, well, if you're working with a client, you probably know that you should know that you're evaluating your client anyway. When they come in, you ask them, how are you doing? But past that, what is important is to know that, however, if you want to know what you're doing is working, you need to evaluate your practice, because you might read an article about intervention X, Y, and Z and find out, read 3 studies that it's an effective intervention for most clients. However, we know that just because an intervention works for most people, that doesn't mean it works with your particular client. I mean, it's similar to medication. Sometimes medications work for some people and not others. And in addition, there are some interventions that either have very little research evidence or none at all. So in that case, it's very important to evaluate your practice systematically and objectively to determine whether your client is getting better, whether they're reaching their objectives and goals. I think I have a duplicate slide there, so let's skip that. In terms of, and we're also ethically bound to evaluate our practice. In the NASW Code of Ethics, there's a whole section, 5.02, called Evaluation and Research, and I believe there's, I just show A and B because they're most applicable to practice evaluation, but I believe they go through M, that talks about other types of research other than practice evaluation. But in the Code of Ethics, it states social workers should monitor and evaluate policies, the implementation of programs, and practice evaluations. And that last part applies directly to your obligation to evaluate the interventions that you're using individually with your clients. Second, in addition, social workers should promote and facilitate evaluation and research to contribute to the development of knowledge. So when you find, this isn't something that you may do at the very beginning of your career, but over time you're going to be doing a series of single system designs. Sorry about that. My phone is ringing. Sorry for the interruption. Note to self, turn off phones before recording. But as you do a series of these single system designs and see, wow, this intervention is working with this type of client, you also have an obligation, an ethical obligation, to promote and facilitate evaluation and research to contribute to, that development of knowledge, that knowledge base, if you've heard of that term in social work. And and that's how the practice of social work can improve. Next, how would evaluating my practice improve it? This may be obvious. You'll have, if you take these measures on a weekly or some measures on a daily basis, you'll have more information from your clients to see what progress they're making toward their objectives and goals. And you'll be able to decide then in terms of their practice whether you should intervene or not. I mean, just because somebody comes to your office doesn't mean you should intervene at all. Through your client assessment and your baseline measures, you may find that this client doesn't have significant issues that you can help them with. It can also help you decide whether to continue an intervention, modify an intervention, as I showed you before, to as far as modifying it by providing more or less of it, or adding another intervention to it, or changing entirely to another intervention. And again, and then finally to when to discontinue intervention altogether. And the question commonly comes up, this evaluation stuff is sounding a lot like research. Unfortunately, if I had to rename this class, I would call it practice evaluation, because it really is different than research. When we talk about research, the primary goal of research is to develop knowledge, contributing to that knowledge base. And when we think about classic research, group designs, where you have 50 people in a treatment group and 50 people in a control group. In those situations, the design, the research design and the duration are fixed in advance, and they're driven by research considerations. Most likely, what's getting funded is usually what it's driven by. And the targets of the intervention are driven by the research questions. And once a research study changes, those research questions are locked in. If we look at evaluation, the primary goal of evaluation is to improve your practice with a client, therefore the design and duration of treatment is dynamic, and it's driven by practice concerns. It's driven by client needs. The targets of the intervention, which are the problems or objectives and goals, are always driven by client concerns. So those are the key differences. And if you still have confused about the difference between single system design and classic research design, please, and I'd like for you to do this anyway, if you're not confused, just peruse at least pages 10 or 11, table 1.1, and look at the characteristics of research and see how they're different between single system design and experimental design. I mean, certainly the costs of single system design are low, whereas for classic research they're high. There are limitations to single system designs. We can't generalize to a lot of people, whereas classic research has more external validity, generalizability, as I look through this list. again, change some of the other things that we've already talked about. Choice of goals, are driven by the client. Those are negotiated between the client and the practitioner, and those can change over time. So take a look at table 1.1, and also take a look at figure 1.1, which also compares experimental control group designs and single system designs. Just the way they look are different, and in terms of the frequency of collecting data is different. Okay, I've just told you that the primary concern of single system design is to cater to your client's needs. And you might ask, well, won't I develop knowledge, from evaluating my practice? And as I said earlier, yes, as you do more single system designs, you might see patterns of that you might see patterns, the same patterns, and that this intervention is good or it's not working. But again, it's not the main reason for doing it. The main reason for doing it is to help your client. Why use single system designs? And that's because traditional designs don't work well for this purpose. But they can be very useful for generating knowledge, which then can be used in practice, which you'll find out, when you're doing your lit review for finding possible intervention for your client's problems. You'll find that most of the research studies use traditional designs because that's what they're designed to do in generating general knowledge that can be used in practice. So they both of these designs have their purpose. In addition, in answer to the question, why use single systems designs to evaluate practice, please refer to page 24, which talks about many of the advantages of using single system designs in practice. And we've talked about many of them, but please take some time to look at that. And, anything I mention also that when I ask you to take a look at might end up on an exam as well. But let's go on. In terms of what are the key elements of single system design, after these are discussed on pages 5 to 8, and this is basically an outline of the class, but after doing your client assessment, which is again due on September 21st, please get started on that. Start thinking about the client that you want to look at. The first thing that you're going to do is specify the target, which is a term used in single system design that means either the problem or objective or goal. So the target could be either decreasing tardiness, where tardiness is a problem, or you could specify it as an objective or goal as increasing school attendance. As social worker, we want to use the strengths perspective, and we'll talk about that when we talk about problem selection and description. The next thing is, after specifying target, is how do we measure that target? We measure that target using a variety of tools. There's 5 chapters in the book that talk about that. There's of course standardized scales that we can use. There are what are called individualized rating scales. There are behavioral observation techniques, and then there are logs, which are essentially journals, which contain more qualitative information as opposed to the other methods, which contain quantitative information. And then we'll also talk about non-reactive measures, which I'm not going to get into. And then also measuring the target, another aspect of that is who is the source of the data. You know, we often think of, standardized scales as being self-report data, that the client fills it out. But in order to get the best picture of what's going on, we want to use different sources of information. We want to get information from the client's relevant or significant others. We want to get information from the clinician. What does the clinician see? And in some cases, we may want to get information from independent professionals. The next element of single system design is baseline and intervention phases, which you've already seen earlier in this lecture. You've also seen repeated measures. One example, I think one example showed you, a measure that was taken daily, and then the depression inventory that was taken weekly. So that is a very important element of single system design, and very different than a classic research design or even a practice evaluation design that just uses pre and post measures. You get a lot of information from getting information throughout the different phases or different time periods during the intervention. Another element is practice design. And when I talk about practice design, I want to, finding my notes, a practice design, within any practice design, and then when we talk about practice design, I'm talking about a specific intervention, maybe AA or cognitive behavioral therapy. There are outcomes expected as a result of that intervention. So that's certainly a key element of single system design in specifying, your problem or your goals and figuring out how to measure it. Evaluation design, these are different there are different single system designs. I've showed you 2 very simple ones, the A-B design earlier, which it was a baseline followed by an intervention, and then an A-B-B-C design, which was the baseline followed by 1 intervention followed by a combination of 2 interventions. And after collecting the data, an important element of single system design is how do we analyze the data. So we'll talk about that toward the end of the class, end of the semester, probably about 3/4 through. And then finally, what do you do with the data? We've talked about the decisions that you can make on the basis of the data, but that's the final element and the most important. Can single system designs be used to evaluate practice on different intervention theories? And basically, single system designs are atheoretical, meaning that you can use them on any theory or theory of intervention. It's not tied to any specific theory at all. Other names of single system designs, if you are looking for single system design articles and you type in your search engine single system designs, you will find a large number of articles, but you can also type in other terms such as single subject design, time series designs, which talks about, that stresses the repeated measures, and then, N=1 design, which talks N=1 meaning the single subject. In a classic research design, you may have N=50 in your treatment and N=60 in your control group. Well, this is just saying N=1 design is a single system design. And then a single case experimental design refers to a more complicated single system design that we'll talk about further down the line when we talk about evaluation design. Why are we using the single system design? There's frankly, a lot of resistance to single system designs. People think it takes a lot of time. There's resistance to change. But we've already given a lot of reasons why the advantages of using it. But two other reasons is that it's inclusive of many clients served by social workers. You can use single system designs with any client population. And then finally, it emphasizes the person and environment focus of practice. It takes into, you can build into your different methods, not just inner psychic factors, but other elements of the client environment, such as, what social support the clients are using, the perspective of the relevant others. Those are two other reasons we're using the single system design. I think the next slide, evidence-based practice represents the, now evidence-based practice, let me, that's a term you might have heard of, and I just want to take a little time to talk about that. It starts on page 13. And basically, evidence practice in other fields may be called best practices. And on page 13, it says evidence-based practice is one of the most important developments in the helping professions, including medicine, nursing, social work, psychology, public health, counseling, and all the other health and human services professions. This is because evidence-based practice holds out the hope for practitioners that we can be at least as successful in helping our client as the current available information on helping allows us to be. Evidence-based practice represents the practitioner's commitment to use all means possible to locate the best and most effective evidence for any given problem at all points of planning and contacts with the client. And, we should be familiar with that. When we go to a doctor, we certainly want to be assured that he's read up on all the latest journals and attended all the necessary conferences to treat our maladies. And we as social workers have the same responsibility. When we talk about evidence-based practice, this term came up in social work in the 1970s, and it's being used more and more. And it's different than, when I say, you need to get, 10 empirical-based articles for your paper. It's very comprehensive. Evidence-based practice. The ideology, and is that ethically clients deserve to be provided with the most effective interventions possible. The methods, the ways that we go about finding and then implementing these interventions, and we do that through comprehensive reviews of the literature. And obviously, in a semester, you're not going to have time to do a comprehensive review of all the literature available on all the possible interventions available for your client. So you're going to be depending upon other some websites. Also, there's a good website. That one's in the book. Also, I just sent you an email on a good website that summarizes these comprehensive reviews for you. And the best way that I found to do that is, just to take your intervention or take your problem and put it in a search engine and cross-list it with literature review, maybe evidence-based practice too. But if you do have, and I offered this to the other class, if you do have problems in finding information about interventions for your problems, let me know. Sometimes finding things in these databases is more of an art than a science, and I'd be glad to sit down with anybody and help them find information. The steps in evidence-based practice, and again, this is something that I don't expect you to do, but I want you to be aware of, because this is something that hopefully we're going to hear more and more about. And in the DSM, for some problems, it has information about the best practices. But the steps documented on pages 15 through 19, take a look at that, are developing a question just as you would in any research study, finding the evidence, finding all the studies, doing systematic literature reviews, and then doing meta-analysis, which is a way of combining what are called effect sizes, the effectiveness of an intervention. It's a statistical process to do that. And then finally, applying the evidence, which involves evaluating the quality of studies and analyses. And that's another thing that you can do on some level, but probably don't have the knowledge to do it in depth. But you can look at the studies and see which ones best apply to your client, and that's the fourth step, combining the evidence with your understanding of your client. and then applying that to your practice, and then using single system designs to monitor and evaluate results. Evidence-based practice, I put a book on reserve in the library. It's a very recent book. It's called Social Work in Mental Health, an Evidenced Approach, and it has these comprehensive literature reviews and best practices for a number of mental health problems. So take a look at that in the library before when you decide on what client problems you're going to be looking at. They don't, unfortunately, it's limited to 6 or 7 problems, but take a look at it. Thayer and Wadarsky are very well-known names in the field, and this is a good contribution to the literature. In terms of what we're going to be using and what we're not going to be using in the introduction, the text explains this, what I consider a very complex 18-step praise model. We're not going to be using that. I think the text is clear enough, and if you look at figure 1.3, that shows the organization of the text and the steps really we'll be going through to teaching you how to evaluate practice. And finally, can I evaluate? Can I get out of this? Can I evaluate my practice without? Can I practice without evaluating my practice? Well, as I mentioned before, you do evaluate your practice. All practitioners evaluate the practice. The question is how best to do it. So my hope is that through this course that I give you some more tools to better accomplish that task. So that's the end of my first narrated lecture. I hope you're still awake, and I guess that's it. So I'll be doing lecture 2 now on chapter 2, and I'll be uploading this hopefully successfully. This was recorded on Wednesday, so there may be a backlog. So if you didn't get it, that's why. I may send a note out about that. Bye-bye.